So mandibular anesthesia, let's do the anatomical background first. And these are the landmarks that we will cover. And this is in your structure list. So you have to know it, everything that's here, but we will go through it. I'm not going to go through word by word because you're supposed to know that already. So I'm going to talk more about the relevant ones, the ones that are directly related to the anesthesia, like this external oblique ridge, the continuation, external oblique line from inside, internal oblique line, which is like this. This is internal oblique line, external oblique ridge, and line. And there is a depression right here that's called the coronoid fossa. Let me just do it a little bit better here. Um, if you feel the ridge, like if you put your finger here and go like down like this and then go up and down, you will notice a depression right here. That's called the coronoid fossa. You also have the lingula here. Lingula means tongue. That's covering the mandibular foramen. And this area here, it's called the retromolar fossa. It's a fossa behind the molars. This is where the name came from. The rest of the structures, I'm assuming that you guys already know. Here it is again. This is the internal oblique line. This is the lingula. This is the mandibular foramen with the inferior alveolar bundle, including nerve, artery, and vein enter. This is the external oblique ridge. This point, this depression right here, is called the coronoid notch, and this is very important, the coronoid notch, as a landmark for mandibular anesthesia. Very important. It's a notch or a depression on the external oblique ridge. The external oblique ridge will continue as external oblique line. One more time, here it is. External oblique ridge, external oblique line. Here is the coronoid fossa. Look how this area is more depressed. I'm exaggerating, but this is more depressed. Otherwise, you have the mandibular foramen and the lingula is partially covering it, and so on. Also, here is the mental foramen, because we will be talking about this. Same thing here. Remember, the lingula is right here. This is the foramen with the inferior alveolar nerve going into it, and this will be our target, so we will be talking about this. These are the two ridges, external oblique and internal oblique ridges. This is external oblique ridge. If you follow it, it will take you to the external oblique line. The ridge will become line. What's the difference? The ridge is more protrusion. The line is faint. It's not as big or as protruded. And this is the internal one. And this is the retromolar fossa. Remember, these are the molars. One, first molar, second molar, third molar. So you see a fossa behind them. Retro means behind. Retro is translated as behind. Another thing is the sphenoid spine. If you guys still remember, this is the whole thing here, the butterfly shaped. Remember butterfly, sphenoid. There is a spine here, right here. It's called the sphenoidal spine. And this is important because it's an attachment of a very important ligament known as sphenomandibular ligament. You will see it. It comes from the sphenoidal spine or the spine of the sphenoid bone, and it will go all the way, if you guys still remember, the lingula, which is partially covering the mandibular foramen. You will hear something. I'm giving you the anatomical background again. You will always in the clinic hear the upper and lower occlusal planes. Means when you close your mouth, or there is a plane or a line that you can get from. Let me just make it a little bit bigger. you will draw an imaginary line between the incisors, like central incisor, lateral incisor here, and you draw a line all the way until the first molar, and this is called the upper occlusal plate. Same thing in down here. So you're making two lines. If you can see it, the red lines, there are two lines, A and B. A is the upper occlusal plate, and B is the lower occlusal plate. So later on, when I tell you get the needle parallel to the upper occlusal plane, you should know what are we talking about here. So that's the importance of the anatomical background. Um, if you guys still remember the pterygoid plates, and there is a hamulus at the end, which is, this is the pterygoid plate right here, and this is the hamulus. Hamulus is coming from hammer. It looks like a hammer, and this is at the end of the pterygoid plate. It's called the hamulus. This is the pterygoid. This is the pterygoid plate, and this is the hamulus. Um, why are we mentioning that? It's because of this spheno, or I mean pterygo mandibular raphe. Pterygomandibular raphe. The pterygomandibular raphe come from the hamulus and go all the way to the mandible, and that's why actually posterior to the third molar, to be specific. Okay, so remember these. Pterygomandibular raphe is very important. You will see it. It's a very important landmark that you will use it in the injection. What are the 2 points of attachment? The hamulus on one side, and the posterior aspect of the third molar is the other end. And not to be confused with the sphenomandibular ligament that we just talked about. We are going to discuss all these. We are going to discuss all these nerves. So let's talk about this. Um, this is a mandibular nerve, the trigeminal nerve, trigeminal ganglion, ophthalmic, maxillary, mandibular, and the mandibular will give you the following branches that you need to remember. This is auriculotemporal, and the name gave it away. Obviously, it goes between the auricle toward the temporal bone, and then you will have this one right here, which is the inferior alveolar, and this one here, which is the lingual, and this one here, which is the buccal. So auriculotemporal, inferior alveolar, lingual, buccal. You need to remember these branches. Here it is again. Auriculotemporal is this. And then you have this, which is inferior alveolar, that will enter through the mandibular foramen running within the mandibular canal. And then you have the lingual, and then you have the buccal. So you have to remember these branches. How about this branch here? It's not a separate branch, it's a branch of the inferior alveolar that's called nerve to mylohyoid. There are also some meningeal branches for the purpose of the lecture exam or something, but our focus will be more on the buccal, the lingual, and the inferior alveolar nerve. Here, this one more time, just to make it more clear. This is the buccal. Bucca means cheek. It's going toward the teeth. This one here is the lingual going to the tongue. And this one here is inferior alveolar. And this is the nerve to mylohyoid. The most important are buccal, lingual, and inferior alveolar. Inferior alveolar, this is the most important. Followed by buccal. Lingual is important for a reason, which is it's most likely it will be blocked as you are working. You do not intentionally try to block it, but actually it's because it's very close to the inferior alveolar nerve. Look how close. If you like, if I'm going to this area here, you will, the anesthesia is liquid solution, so it's going to spread, and most of the time it's go to the tongue. Um, so that's why we're talking about this. Here is a clinical point. If you guys want to remember this, always give your patients heads up. You will tell the patient, if you're working on this, tell him most likely your tongue will be numb for a few minutes. So he know what to expect. The more you explain what's going to happen, the more confidence the patients will have. He told me already that my tongue is numb. Now it's numb. Instead of he like getting scared of why my tongue is getting numb, you already told him most likely your tongue will be numb. You're not trying to numb it, but it's very close. Look at the point, look how close. Okay. After, remember this is inferior alveolar nerve. It will be giving like alveolar branches that will go to the teeth through the apical foramina of the roots. It will enter inside and go to the pulp. It will go like branch, branch, branch until it comes to this foramen, which is the mental foramen. It will exit out as a mental nerve, but another part will continue. So you give off the mental branch, and the rest will continue as incisive nerve. Because if you come here and exit out, how about the rest of the teeth? There is a continuation. So here it is again, inferior alveolar nerve, right beside it, very close, lingual nerve, and buccal nerve is all the way more up here and more medial. Here is the inferior alveolar nerve. Look at the branches, alveolar branches will enter the roots of the teeth to the apical foramina, go in, go in, go in, until this point. When the lingual nerve exits, the rest will continue. Look at this here. Let me remove this and make it a little bit bigger. So look at this. When you get into this foramen, the mental nerve will exit, but the rest of the nerve will continue. This to get to the rest of the teeth. And this continuation is incisive nerve. So one more time, inferior alveolar nerve, as it is passing through the mandibular canal, it will give off alveolar branches to go to the teeth until it get to the mental foramen. At the mental foramen, mental nerve exit, and the rest will continue as incisive nerve. So mental and incisive, these are kind of branches of the inferior alveolar, or the bifurcation, or the end, the branches. Here it is again. The green is inferior alveolar. Look at all these alveolar branches coming out of it. And then it will give you this, which is inferior alveolar, which is the mental, I mean, and the blue here, the continuation is incisive nerve. Here it is again, but this is an actual picture, a picture of an actual bone. So you see here the inferior alveolar nerve giving you the alveolar branches entering the roots of the teeth through the apical foramen until it come here, mental nerve exit, and the rest will continue as incisive to give the rest here, 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 here. So those take their alveolar branches, center incisor, lateral incisor, canine, first premolar, they get the alveolar branches from the incisive nerve. The incisive nerve is the inferior alveolar nerve. It's a continuation, I know, but just to be more specific, in case if you wanted to target the incisive nerve itself, and you will see that. This is extremely important as usual, but it's very simple because it's not as complicated as the territories of the maxillary. You don't have a lot here. Here, if you do the inferior alveolar nerve, you get everything except the buccal aspect of the three molars. which is yellow here. That's it. So this is a lot easier here. Okay, so inferior alveolar nerve will give you all the teeth, all the lower teeth. Yes, not part of them, all of them. And the inside, which is the lingual aspect, yes, all of them. The outer aspect, yes, most of them. So you get everything done except the last three molars, or I mean the molars, the three molars, the buccal aspect or the outer aspect of it. So if you're working on the first five, the first the central incisor, lateral incisor, canine, first premolar, second premolar, all these five, you're okay with one injection, which is the inferior alveolar. But if you're working on one of the molars, you have to give a second injection, which is in this case, it's the buccal. Incisive, if you do the incisive nerve, you will see the technique. But if you get it, remember what the incisive nerve is feeding? All these five nerves. I showed you that in the picture. So it's going to give you the five, those five, plus the outside. This is for the incisive. Usually we do the inferior, or you guys are going to do the inferior alveolar, but just for your understanding. This picture is specifically to mention that there is another nerve that's called the buccal nerve, which is a branch of the facial nerve. So remember, there's a buccal nerve of mandibular and buccal nerve of facial nerve. The buccal nerve of mandibular, most of the time they call it long buccal nerve. Do we have to say that? No. Buccal nerve of mandibular or long buccal nerve. The facial is called buccal nerve of facial. This is one thing. The other thing I want you to notice here is the buccal muscle right here. And this is the buccal fat bed, or yeah, fat bed. Same thing here, the buccal nerve, but also there is a glossopharyngeal nerve in this area here, which is a neurostructure list. Okay, one more thing that you guys need to know, because it's a neurostructure list, is this trigeminal nerve, trigeminal ganglia, ophthalmic, maxillary, and mandibular. Of the mandibular, you have inferior alveolar and you have lingual. There is a nerve that will get the taste sensation. It join the lingual nerve and go here to the facial nerve, and the facial nerve will take it to the brain. And this is called chorda tympani, chorda tympani. So chorda tympani, part of it is with the facial nerve and part of it with the lingual nerve. How does it reach the tongue? Through the lingual nerve. How does it reach the brain? Through the facial nerve. So this is something that you need to know. I know it's not directly related to the anesthesia. Somehow, if you got it, if you anesthetize that for whatever reason, the patients might have a weird sensation like with their taste or something. So it's kind of related, not directly, but it's something that still you need to know. Other soft tissue landmarks, we have the sphenomandibular ligament. We talked about this one here, which come from the sphenoid, the bone of the sphenoid, or the sphenoidal bone here, and it goes all the way to the lingula here. The other one come from the styloid process and go to the angle of the mandible right here. Okay, so sphenomandibular and stylomandibular. Remember, they all end with mandibular. So sphenomandibular, stylomandibular. These are two ligaments that are attaching the mandible to the skull and avoiding overstretching. This is just a relationship between these nerves and arteries. Just understand that the maxillary artery, the maxillary vein, auricular tempora, they pass under this, which is the neck of the mandible. And here, this green here is the sphenomandibular ligament, and so on. Here is one thing that's also important here. This muscle here is a buccinator muscle. This muscle here is the superior pharyngeal constrictor muscle. Superior pharyngeal constrictor. You have superior and middle and inferior pharyngeal constrictor. The pharynx, when you constrict the pharynx, there are three muscles, one on top, one in the middle, and one that's inferior. I'm talking about the superior one now. Remember the pterygomandibular raphe that we talked about? The pterygomandibular raphe is the attachment of buccinator muscle in the front and superior constrictor in the back. And you will see how that is important. The pterygomandibular raphe is very important, okay? Because it's an attachment. So if you approach it, the needle can come to one of those because you will be going in relation to the pterygomandibular raphe, and you will see. But just remember what I'm telling you right now. Um, this is what I want you to know here. These two sulci. Remember when you talked about the maxillary side, we said this is called the vestibule, which is the space here, and this is called mucobuccal fold. Here it's the same thing, but this is called sulcus instead of vestibule. From outside, it's called the gingivo-labial sulcus. The sulcus between the gingiva or the gum and the lips. The name give it away. Just understand the name. The other one is between the gingiva and the tongue, which we call it the gingivolingual sulcus. How about this? Still mucobuccal fold. So this does not change. Mucobuccal fold. Whether we're talking about the maxillary or the mandibular teeth. In both cases, it's called mucobuccal fold. What's different is the sulcus versus vestibule. I talked about the pterygomandibular raphe, and I just showed you how in front of it, anterior to it, is the buccinator muscle, and behind it is attaching the superior constrictor. Here is the pterygomandibular raphe. Okay, very, very important. When the patient open his mouth, you should see pterygomandibular raphe protruding like this, and this will be your landmark, and I will show you what I mean by that. Remember the retromandibular fossa? There is soft tissue on it here, and we call this soft tissue located on top of the retromolar fossa. The bone itself, we call it retromolar fossa. When you put this pad on it, we call it retromolar pad. And this will be a very important landmark. Look at this injection here. We'll be talking about this um, depression right here. We'll talk about it. Now the techniques of the mandibular anesthesia. Most of these techniques are going to target the inferior alveolar nerve for a simple reason, which is inferior alveolar nerve feed all your lower teeth inside and outside, lingual and buccal aspect and the teeth itself, except the outside of, or we call it the buccal aspect of the three molars. This is the only thing that's exception. So you're going to do the inferior alveolar nerve anyway. You're working on the mandibular teeth, you have to do the inferior alveolar nerve block. So here are the techniques. There is a traditional technique or Halsted, traditional, standard, cross arch, three names or four names. Traditional, Halsted, standard, cross arch. You have to remember these. I don't know which name you're going to be using in your clinic. They will tell you, let's do the cross arch technique. I know it's called Halsted or traditional. No, traditional, Halsted, standard, cross arch, all of these are the same. And this is the most commonly used one. And the way you remember it is Halsted, stead, remind me with standard, stead, standard. Then you have the Gauge, you have the Akinosi, you have the ART, and you have the RPM. We will talk about those. Traditional whole state technique. Simply, what you're going to do is, remember when I told you that this is the external oblique ridge that will become a line, but there is a notch right here. This notch is called the coronoid notch. Look at this. This is your thumb. You're going to put your thumb, as you see in this picture right here, on the same side, and you go across. Actually, you can do it in your own mouth. You can put your thumb inside your mouth and go up and down along the external oblique ridge until you feel a depressed point. There is a depression, and this will be your coronoid notch. Once you find it, stop. And then find here, you will find, uh, all right. So this will be your thumb, and on the other side, right here, you will see your pterygomandibular raphe. Go exactly, draw an imaginary line exactly in the middle of the tip of your thumb, and go take it to the middle of the pterygomandibular raphe. And this will be your point of injection, like here. Not exactly in the middle, it's closer to the pterygomandibular raphe. Okay? And obviously, you're going to make two negative aspirations and inject. But how about your point of entrance? Remember, the technique is called traditional standard Holstead cross arch. How to get it? One more time, find the pterygomandibular raphe. Find the coronoid notch using your tip of the thumb. And then draw a line and go not exactly in the middle, closer to the pterygomandibular raphe, closer to the middle of the pterygomandibular raphe. This is your point. But your syringe or your needle will be going cross arch, meaning from the right to the left if you're working on the left side, or from the left to the right if you're working on the right side. So we're going to go in this angle. This can be confusing because you can go to different spots. Can we be more specific? You can. It is contralateral second premolar. Find the second premolar. You count central incisor, lateral incisor, canine, first premolar, second premolar. So add the second premolar, go with the needle, and go to this point. When you do this, you're going to target, look at this here, you're entering here, look at this picture, you're entering here, second premolar, and you go in this angle, you already decided the point, which is in between the middle of the tip of your thumb and the middle of the pterygomandibular raphe. Find the middle and then go a little bit closer to toward the pterygomandibular raphe. And you go up with the needle, and you will ultimately go like this. You will go like toward the mandibular foramen, like right above the lingula. And what are we going to get? Yes, yes, Alicia, go.
Okay, okay. I'm getting a little confused. When you do when you cross over with the syringe, um, you make the injection. Am I gonna like swing my syringe where it's like parallel with my occlusal table, if that makes sense, before I
That
start to like inject the solution or anesthetic?
I'm not sure about the question. I'm not sure if I understand.
So, like in the picture, how it's like diagonal or crossed in that
Oh,
first picture.
yeah, you go parallel to the occlusal plate
Ye-
if that's what
Yes,
you're asking about.
Yes, so before I inject the solution or the anesthetic, I'm gonna swing my syringe parallel, so it's parallel to the occlusal.
Yes, yes, it is parallel to the occlusal plane, and it will go all the way until you are going in an angle, so you will end up almost touching the bone. And when you do that, let me say it this way: when you are going to go parallel to the occlusal plane, the lower occlusal plane to be specific, and when you get the needle in there, um, there is something that I want you to remember. If you get like a quarter of the needle only, and then the bone stopped you, you are not in the right angle. If you go like further and you take like three quarters of the needle, you're wrong. It's supposed to be like half the way. So if that the case, you're going too early or too early anteriorly or to the back. So if you go more to the back, you can end up going to the buccinator muscle, or you can get into the superior constrictor muscle. But if you see here in this picture, find your point of entrance, find the second premolar, put your needle parallel to the occlusal plane and enter in. You should get like half of the length of the needle. If it is less, if it's a lot less, the angle is wrong. The angle that you got is wrong. It's too early. If you go all the way like three quarters of the needle or the whole needle, you went too far. Take it out and reposition. It should go like about half of the length of the needle. Okay. Uh, do we
Yeah.
have any questions? Is it okay?
Yes. Thank you.
Okay, you're welcome. You guys feel free to ask me anytime you want about anything here. If it is something that's too in like deep into the dental practice, I might not help with that. But the vast majority, as long as we're talking about the academic part, I'll be able to help. Here is the point again. The tip of your thumb go to the middle, and your thumb now is in the coronoid in the coronoid notch. On the other hand, look at this. This is the pterygomandibular raphe. Don't worry, it will be very obvious. When the patient opens his mouth, this is going to stretch and it's going to protrude, so it's not that hard. In between your thumb, which is the coronoid notch, and the pterygomandibular raphe, there is depression. This is called the pterygotemporal depression. I don't want you to get it wrong. Pterygomandibular raphe, pterygotemporal depression, pterygotemporal, pterygomandibular raphe or fold versus pterygotemporal depression. Pterygotemporal depression is that depression in between your thumb, which is the coronoid notch, and the pterygomandibular raphe. There is a depression in between those two. And this is called the pterygotemporal depression. And this is where you're going to insert your needle. And again, if this is the tip of your finger and this is the pterygomandibular raphe like this, you draw a line in between. You don't go exactly in the middle, you go here. This is more um, a better point for your entrance, or this is the point of your entrance. Two negative aspiration, and then you're going to inject. By the way, let me give you this advice. Um, when you have the chance to get one of these syringes, try to practice dropping one drop at a time in a period of 15 seconds versus 30 seconds. Some of them you will go 15, some of them will go like 30 seconds. So here is half, let's say you're doing whatever, ASA for example, or PSA. I'm gonna do half of the syringe. I'm gonna do this half in 15 seconds, let's say. So you need to make like go slowly, 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 and watch yourself while you're doing that. So in order to not to go too fast, not to go too slow. So this needs some practice. When you have an access, and I think you will. When you have an access to this, one of these syringes, time yourself. 15, 20, 30 seconds. So when you see the technique is asking you to do it in 15 seconds, you know how to be patient or 30 seconds, which is even more. You have to go like slowly, slowly, slowly. Okay, so try to practice that when you have the chance. Here it is again. This is Alicia. This is what you were asking about, and here it is. It's parallel to the occlusal plane, kind of, not 100%, because you go up a little bit. But the most important is the needle or the syringe is on the second premolar or in between the first and second premolar. And the point here is clear. You make the point first before doing anything, which is again in between the pterygomandibular raphe and the middle of the tip of your finger, of your thumb specifically. I want you to notice something here. Look at this. This is the inferior alveolar nerve, and this is the lingual nerve. So if I'm going to put the anesthesia like here, the solution is going to spread and get into the lingual nerve. And that's why I keep on saying, tell the patients that most likely your tongue will be numb. The patient will have more confidence when you do that. And instead of leaving the patient, all of a sudden he feel pain, all of a sudden he feel like his tongue is numb and he don't know why. So this is always a good practice. Okay, here it is again. The coronoid notch from one side, the pterygomandibular raphe from the other side. Draw the line from middle to middle, get the middle point, and then go a little bit in toward the pterygomandibular raphe. Here is your point again. This is longer than this. Gauge technique. I will tell you how I remember that, but again, you can find your own way. I always say gauge, go above the gate, go high above the gate. Like the gate is a mandibular foramen. I will go up with the gauge. Go up above the gate. You don't go like this. This is traditional. You're going toward or just a little bit above. But gauge, go up above the gate. You go all the way up. And the reason for that is, just let me tell you that you insert distal to the second maxillary molar, and your point of entrance is very important. Remember the traditional, we said the second premolar, the gauge is the second molar. Find the second molar, and I will show you. Look at this. In the traditional, you're going here toward the mandibular foramen. In this case, you're going toward the condyle, you're going toward the pterygoid fovea, you're going toward this, toward the head. Why are we going up like that? Because the branches that I told you guys about coming off the mandibular nerve, some people have exceptions. They have something called accessory nerves, which is for we don't know why. Some people will have it. Like a nerve will come from the mandibular here and go like this to one of the teeth. And you have no idea about that because this is rare in certain occasions. So what's happening here, or actually, sometimes it even come from, uh, let me just do it a little bit like this. For whatever reason, you see like a branch coming from the buccal nerve and going to the teeth, or even from the lingual nerve. These are called accessories. It's not supposed to be there. But remember, anatomy is the structure in the vast majority of people. This is what we call it anatomy. We say it's normal. It doesn't mean other people are really abnormal, but the vast majority of humans will have it like what we know. But some people will have something different, like these accessory. What should I do now? In this case, if the patient might tell you if he already know, or maybe you're doing like you're trying to work on, let's say, the second molar, and you did everything correct, and the patient still feel it. Give him some more time because people are different, and the spread of the injection. Give them 10 more minutes. Are you okay now? Do you feel numbness? No, I don't. You still feel it? Let me just poke you a little bit. Do you still feel pain? Yes. Okay, give it 10 more minutes. Do you still feel it? Yes. So if that's the case, maybe this patient is having accessory nerves. So if that's the case, what if I go all the way up here to the mandibular nerve itself? If I go all the way up to the mandibular nerve, it's equal to the maxillary nerve block. Do you guys remember the maxillary nerve block? Well, everything will be blocked. This is the same. Everything will be blocked. Everything, you name it. The not only the inferior alveolar and the lingual and the buccal, but also if you have any accessories, it will be blocked. So we will leave gow gate going high above the gate to these exceptions if they have accessories. And here is a way to do it. You will find the second molar here. Um, this is your, like here, and the lower, the mandibular teeth, find the second molar. This is one. And your point of entrance will be right here. And what is this? Look how high you're going. This is your third molar. You go like behind and like here in this area behind the third molar right here. Okay, so this is where you enter, but I mean, this is your point of entrance. But where do you get the syringe itself? You get it right here. Okay, so this is your point, and you're going up. Remember, if you're doing the traditional, you will be here, like the middle of your finger, like this. You will be entering here, right? Compare this, you're going all the way up. You might say, okay, but this is like maxillary teeth. Are we doing the maxillary teeth? No, we're not. It's just a way, an alternative way to get all the way up. Instead of just going to this point, which is the mandibular foramen, you're going all the way. And look at this picture right here. The other picture, see how high it will take you? It will take you up all the way to here, which will ultimately spread over the mandibular nerve itself. So this is the important things that you need to know. Your landmark is your third molar, okay? And your point of entrance or your other landmark is the second molar, and you go obliquely like this, and you two negative aspirations, and then you're going to inject. Here is the gow gate, and what's going to be blocked? Everything. You're doing the whole mandibular nerve. Do I need to do any additional injections? No, it's just one, because you got the mandibular nerve. What else do you need? Like, do you need the buccal nerve, for example? No, you don't need anything else. So you're done. So look at this yellow here. You got everything done, including this part right here. And what is this part? This is the territory of the buccal nerve, including the lingual nerve and including everything. The akinosi. Akinosi technique is another technique that you will hear about. These techniques are not very commonly used, by the way, but I'm just giving you an idea because just in case if you hear about it. Um, Akinosi, the way I remember it is akinosi with the mouth closey. Akinosi with the mouth closey. What does it mean? What I'm trying to remember. Some patients, occasionally, you see some patients cannot open their mouth wide. So can you do something alternative with the patient, with the patient's mouth closed? Remember, normal, you need the patient open his mouth and go in. Most of the time you go from across, from the other side. In this case, no, that for whatever reason, the patient is having an issue opening his mouth for some reason. And you need to do something. You need to still work on the patient. He's having pain or whatever. Trying to open it, it didn't work. What should I do now? You do the same thing, but while the mouth is closed. Akenosi with the mouth closed. Obviously, you will not go across. It's not cross arch in this case. It is actually from the same side. So these are the differences. Akenosi versus traditional. Number one, the mouth is closed. Akenosi with the mouth closing. Number two, you go in the same side, not across like others. And you're going to put the syringe parallel to the occlusal plate of the maxillary teeth. Look at the occlusal plate. I talked about this. You'll go above that, parallel to it, and you will go in. Ultimately, you will get into the mandibular foramen anyway, but you get it with the mouth closed, and you get it from the same side. And what are you going to get out of this? Exactly the same as the traditional. So akenosi is just an alternative to the traditional standard Halstead cross arch, whatever you want to call it. It's an alternative, but the mouth is closed. So look at this yellow. It's the same territory. So obviously, in this case, if you're working on the molars, you need to do those three through an additional buccal nerve injection. ART or anterior ramus technique is another alternative technique that's getting some popularity. And in this case, you will avoid the maxillary artery, the maxillary vein, and the joint, and all that. You are going to avoid these structures. Um, you feel the coronoid notch just like normal, and you're going to estimate along the notch until the posterior molars. And let me show you this here. So you're going to go, first of all, you're going on the same side, okay? um, the second thing is you're going to go uh, a little bit away. So we're going behind it, like here. You go like this from the same side, and this is called the ART technique. Okay, um, so it's a little bit modification of the traditional. You're going to the same side, um, but you're going to go from this. It's alternative to traditional. You go from the same side, and in this case, you are avoiding to go like prematurely or go toward the maxillary artery or something. The maxillary artery and these things will be here. So instead of going like this, and you might go like here, you go from the same side and you just go behind the mandibular foramen. I mean here. So we're going to this point here from the same side, and you're avoiding this area. Remember, the maxillary nerve, I mean the maxillary artery, the maxillary vein will be in this area here, and the joint and all that stuff. So they are saying if you do it like this, you're going toward these structures. To avoid it, go from the same side and just go behind the mandibular foramen. RMP is, or also known as direct anatomical approach. If you watch the videos for Dr. Morris' lecture, he and somebody else, I don't remember the other dentist, they did some modification and they came up with this RPM technique or direct anatomical approach. And in this case, they do the same as ARP, but they go a little bit higher than that. So remember the ARP, you go from the same side. It's not cross arch. The ARP is not cross arch. It's not the Halstead. It's not the traditional. You go from the same side, not the opposite. So in this case, you simply um, you simply put your finger the same way on the coronoid notch, but instead of going uh, like in between the middle of your tongue and the pterygomandibular raphe. In this case, you go on the top here. So instead of this, you will be here. So comparing, what's the difference? ARP and RPM, both of them, you go from the same side, not from across, like the traditional Halsted, the most commonly used one. This is number one. Number two, your point is this red star right here, which is on top of the tip of your finger, not in the middle. So you go up a little bit. And why they are doing that? They are saying that you're doing this to do something closer to the gow gate, but you don't go that high. So you don't miss anything and you avoid muscles like the buccal muscle, superior constrictor, the veins, the stuff. So here is here it is the RPM as another alternative. If you're working on one of uh, the molar teeth, you need to get the buccal nerve, also known as long buccal nerve. You need to block this nerve as well. Your landmarks here are going to be um, you will need to find the third molar, which is this third molar, and go toward the anterior border of the ramus, like the anterior border of the ramus here, and you just inject in between right here. Okay, you pull out with your thumb to flatten this area and go in this point right here at this point. Uh, Let me just do this. So here it is. What should I find? With your thumb, find the anterior border of the ramus, and then find the third molar, and you go behind it and a little bit lateral to this point right here. This will get you to the buccal nerve. You do the aspiration, negative aspirations, and then you go slowly inject. And again, this is needed only if you're working on the three molars. Oh, and you go parallel to the occlusal plane of the mandibular. Look at this. You're going to parallel to this. You're not going in an angle. You go parallel. Here it is again. Find the third molar, which is this. Find the anterior border and go behind it like here. Go behind and a little bit lateral to the third molar. And while you're going, you go parallel. Look at this to the occlusal plane, like this picture right here. And you will end up getting the buccal aspect of the three molars on the same side. Mental nerve block. Remember here we have trigeminal nerve, mandibular nerve, giving you the branches. Inferior alveolar nerve, enter from mandibular foramen, run within the mandibular canal. At the end, it will exit from here to be the mental nerve, and the rest will continue as incisive. If you wanted to get the mental nerve, you're going to get the needle as you see here. Okay, you can actually feel it. You can feel the mental foramen, and you go into the buccal fold or the mucobuccal fold adjacent to what? To the first premolar. Find the first premolar, try to feel um, the mental foramen, and then you go, as you see here, almost parallel, a little bit of an angle, and you will get to the mental nerve as it is exiting from the mental foramen. It will go to the mental foramen, but you're not trying to push the anesthesia inside the foramen. Why? Because I'm working on the mental nerve only. If you push the anesthesia into the mental foramen, it will enter into the mandibular canal and it will end up doing the incisive nerve block, which is another technique. So one more time, if you're working on the mental nerve only, you need to get the mental nerve as it is exiting out the mental foramen. How to do that? Find the first premolar, insert into the mucobuccal fold of that until you get, and you will be stopped by the bone of the mandible, and inject, not inside. You're not trying to get it inside, you're trying to get it to just the mental nerve. And what's going to be anesthetized? This area right here. If you need to work on this area for some reason, you're going to do the mental nerve, which is on top of the mental bone right here. Here it is again. You will end up getting this area here. And look how we're going toward the mental foramen, like this. Incisive nerve. This is very close to what we just talked about, but the difference is you're trying to get the anesthesia within the mental foramen to enter through, or to go to the mandibular canal, and it will end up working on this, which is the incisive nerve. Okay, this is another way. And as far as I know, when you do the injection, you like wrap around the mental foramen, so that when you inject, the anesthesia will be on the top of, or very close on the mental foramen. And when you like wrap it a little bit like this, it will get in and inject more while you're wrapping it. Inject, rub, or push it a little bit. So it will get inside, and you will get the incisive nerve blocked. And if that's the case, obviously the mental nerve will be blocked anyway. Okay, so you're getting the mental nerve on your way. And this is called the incisive nerve block. So where is the area of injecting? RPM and Gauge techniques are the only techniques where you don't have to do. Yes, my son. The RPM and Gauge, you do not need to do additional anesthesia because you already got it. For the Gauge, yes, that's 100%. For the RPM, I'm not 100% sure because I don't know if we're high enough to get the buccal nerve or not. For the Gauge, that's for sure. For the RPM, I'm not 100% sure. You can ask Dr. Morris about that. He's the one who did it. In my uh, the ART, no, the ART definitely not. Okay, so Gauge, yes, this is the only injection that you need to do in order to get everything anesthetized, because you get the mandibular nerve. Put this to the side. ART is not much different than the traditional Holstead technique. It's only you do it from the same side rather than across, or the contralateral like the traditional. So this is for the ART. In case of the ART, if you're working on the molars, you still need to do the buccal. How about the RPM? This is the only one that I'm not 100% sure about it, because it's not high enough to get the mandibular nerve. Um, so I'm not 100% sure. I don't want to say something that I'm not sure about. You guys can ask Dr. Morris. He can tell you. I'm assuming that it's not high enough, so we probably need the buccal nerve still the long buccal nerve. So, but I'm not 100% sure, just to be honest. Okay, you're welcome. So, but otherwise, I think ART, Gowgate, Halstead, Akanosi, I think all that is clear. The only one out of all of those that get everything is Gowgate. Otherwise, everything else will need additional um, if you are working on the molars. Okay. So incisive nerve, where are you going to enter? The mucobuccal fold. at the mental foramen. You can feel the mental foramen, by the way. You can try to feel it. Otherwise, you will go the same way as we did with the mental nerve block. But you're going to push on it so that the anesthesia is going to get into the mental foramen and go to uh, the mandibular uh, canal, and you get the incisive nerve. Landmark here is the premolars. If you don't feel much of the mental foramen, you can get it across the premolar, first or second premolar. Okay, so we're almost done. We have only the video. Do you guys want to watch the video now, or do you want to watch it on your own? You want to watch it on your own, but make sure to watch it. Okay? If you want to do it on your own, that's fine with me. It doesn't matter. I'm gonna watch it with you. That's all what I'm doing. But make sure to watch it. It's the last slide, and you will see it also in Blackboard. Okay?